What's up, you guys? My name is Miguel, fellow Xray Tech here, giving you your daily dose of radiation. In today's video, we are covering post reductions in the emergency room. So to give you context, I am a night shift Xray Tech, been doing it for about 4 years. So we will be covering the different forms of post reductions, what to do, when not to do, what to expect. So to give you context, it all kind of depends how it's broken. Will determine how the doctor will choose to. Sometimes stuff are broken and the emergency doctors are trying to put it back in place, maybe kind of set it back. Sometimes they can kind of like it just got popped out, so they're popping it back in, like a shoulder or maybe a finger or something like that. That can be easily just popped back in. Other stuff is broken and they'll just try to adjust it and kind of set it in a better place, so whenever they go get surgery, or maybe the orthopedic doctor comes in and kind of maybe adjusts or fixes it with surgery, it'll be in a better position. Or sometimes they'll just put a cast and just let it heal, especially if they're little kids. So for a regular adult, let's say their shoulder got dislocated, right? So if it just got popped out of place, typically what they'll do, depending on the pain tolerance, sometimes they are awake. Majority of the times they'll put them to sleep, and they'll give them some propofol, and they'll do like a little timeout, and that usually takes between 20 to 30 minutes just for the nurses to get everything set up. The actual process itself doesn't take too long. It takes like maybe a few minutes, depending on how hard it is to pop it back in place. But essentially the emergency doctor will kind of pop it back, and then you'll shoot just like a neutral shoulder, just a one view typically. Sometimes if you shoot like neutral shoulder and the doctor's not sure if it's in place or not, sometimes they'll have you do a wide view. You're just gonna kind of have to be careful, because sometimes if you adjust the patient too much, you could pop it back out of place. So you have to be careful. Most doctors, just a one view will be fine. Sometimes if you can't get the wide view, sometimes they'll put them through CAT scan just to get another view, but typically that would be about it. Now for something like a wrist, if it is just like broken, depending, sometimes they put them like a little arm contraction. Sometimes they'll just pop it back in place and you'll just do an AP in a lateral view. Sometimes the doctor will be holding it up and you just have to like cross table it and just adjust it. And if it is in the right spot, sometimes they'll cast it, sometimes they'll put it in a sling. Majority of the times they'll cast it, and then you'll shoot another one after it got casted, because sometimes bones move and they may have to readjust if it's too bad. Usually it gets done on the first try. Sometimes if the doctor's not happy, it could be 2. The most I've ever seen was 3 times. Certain stuff they can't really fix, like if it got shattered too bad, the best they will do is maybe put the patient in a cast, and that'll be about it. If they feel like they can't fix the situation, they'll usually, if it's really bad, like a femur completely broken or shattered, then usually the orthopedic doctor comes in the emergency room on call, and they'll kind of get a game plan rolling. Or if it's something like really severe and it's like almost involving some life or death, they will come in and the surgery will get done right there and then, and it'll involve like the ortho doctor and the neuro, depending on what situation's going on. Certain views, like if it's broken down here, sometimes it's kind of hard to you'll have to like the lateral's pretty easy to get on those, but sometimes you'll have to like angle the tube in a weird way, or like get the cassette and like up here, like you'll have to get creative, because sometimes you can't really especially if they're already casted and the patient's awake, they can't really, they can't move that much because they've been casted up. So it's like limited mobility. So you may have to work around some like weird kind of pictures. Like, let me explain. Imagine this is the cassette. So if you're trying to shoot like this bone right here, usually a lateral, you just like place the board in the back and then you just cross table. But for the AP of the lower forearm, like for the like sometimes it gets hard because like sometimes they'll try to lay it down and you'll just have to angle different ways to get it. It gets complicated. Sometimes it gets creative. If they're passed out, it's usually more easier to get the pictures because they're just like, you can just kind of adjust to how it is. Once they start waking up and they start, you know, getting conscious again, sometimes it is harder for them to like position it how you want. So sometimes it's easier if they're already like still passed out with the propofol. What other stuff? Usually, if it's something's broken or they're doing a post reduction, like we'll shoot it, it gets red, and then sometimes it takes like an hour and a half before they even get to them, depending how busy the emergency room is. Like I've shot stuff like at 10 p.m. and I didn't get to like get back in the room to like 11:30, sometimes even 12, depending on how busy it is. So it could take a while. Just like getting the nurses, getting the respiratory, getting everyone there, and getting the whole, because they do a little system, because since the patient has to get knocked out with the propofol and put them to sleep, the timeout as they call it, they have their own little protocol of what they do. It involves a lot of documentation, a lot of nursing stuff, and yeah, you stuff that usually we don't get involved in. But what am I gonna say? But yeah, it could take a while. So what else do we have on this subject? Most rads don't really complain if like you can't really get the most optimal view, especially if it's already broken. Just get like the best you can and just kind of document what you can. Usually just a 2 view is all they need technically, because you know, with the lateral or AP, depending on how it's broken or how it's post reduction, like you can see like if it's placed in the right spot. Certain places they do use C-arm to get it done. Ours, we don't do C-arm. It's just done in regular X-rays. But I've been told by certain doctors that they do use C-arm in certain locations to get it done. But usually the people in surgery will get involved in that world and they will take care of that. But yeah, it's been your boy Miguel. I'm getting ready to go to work at the night times, and I recommend it to anyone. If you're still watching, I appreciate you, and as I educate you in this beautiful field of radiology, not too many people make videos on this beloved field. I am here to educate you for the free. I will never ask you for any money. Like, I'm just here giving you the knowledge that I've acquired. And yeah, it's been your boy Miguel. We'll see you on the next one.